Now, fast forward a few years, and in 2021, this chap here, Professor Bart Curry, Professor of Infectious Diseases in Darwin, in Northern Australia, he published a 30-year case series of more than 1,000 patients. And the most remarkable thing in this paper was the fact that the mortality over that 30-year period was only 12%. And in fact, over the last 5 years, it was only 6%. So that's quite a dramatic change, and it's a target for everybody to be aiming at. And what I'm going to try and do now is just review the last 40 years in about 20 minutes, talking about aspects of the disease such as awareness, diagnosis, susceptibility testing and treatment with antibiotics, but also very importantly supportive management, and then try to put it all together. And I don't know if anybody actually reads paper journals anymore, but if you had picked up a copy of The Lancet at the end of October, you might have seen that melioidosis actually made it onto the front cover of The Lancet. But the point was that it's a disease which is so neglected that it's not even on the official list of neglected tropical diseases, which is quite remarkable for a disease that probably kills, getting on for, according to modelling, 100,000 people a year worldwide every year, and has all the other features of a neglected tropical disease. And the problem is that a lot of people haven't heard of it. Certainly the public surveys in Thailand have shown that there's very little public awareness of melioidosis, even amongst the high-risk groups such as rice farmers, but also amongst healthcare professionals. There have been many initiatives. This is one from Laos, the L-Team meeting that happened back in 2019. There have been similar awareness-raising drives, initiatives in countries like Bangladesh. But the thing is, you have to keep going. You have to keep raising awareness, and you have to make sure, as far as health professionals, that you get into medical schools, into training systems for laboratory staff, and it's not something you can do once and then forget. So diagnosis, the organism Burkholderia pseudomallonite, it's a gram-negative bacterium. It's actually very easy to grow in the laboratory, and culture remains the gold standard for diagnosis. Although this paper that was published a few years ago by my colleague Limaturotsa from Moru suggested that the sensitivity was only 60% of culture. I actually think it's probably higher than that, as long as you get the right samples from the right patients. The right patients, essentially anybody with a fever, but particularly if they have one of the predisposing conditions, such as diabetes. There's a very strong association with diabetes. If they have contact with soil and water, the reservoir of the organism is in soil and surface water. If they present during the rainy season, the disease is much commoner in the rainy season, and if they have some of the characteristic features, such as pneumonia, abscesses in the liver, in the spleen, in the prostate. And the right samples, well, from all patients we should be doing blood cultures. We should also try and get urine and, at the very least, a throat swab if we have the right laboratory set up. And most important of all, if you have an abscess, drain it, send the pus to the laboratory. Pus is always better than a swab of pus. And if you can get good quality sputum from a patient with pneumonia, so not just saliva, but something from the lower respiratory tract, then sputum. So for some of these samples, such as the throat swab, sputum, the urine, selective media will help to increase the isolation rate. And we've used for many years now a medium called Ashdown's medium. Unfortunately not available commercially, but it does increase the isolation rate. So what this is about is identifying foci of infection using imaging, using clinical examination, and sampling those foci. And I think if you were able to do that, the sensitivity of culture is probably higher than 60%. Serology is a problem. The most widely used serodiagnostic test is the indirect hemagglutination test. It's an old-fashioned test. The antigens involved are very poorly characterized, and there are problems with both sensitivity and specificity. It's not standardized, there's no international quality assurance scheme, and it's really not a very good test. There are better tests under development using much more well-characterized antigens, and some of our colleagues in Moru are working hard on this, particularly Narisa Chantradeep, who was in Lao yesterday, but is sadly not here today. So there will be better serological tests to come. Molecular testing, obviously, is very popular. There are many papers about PCRs for Burkholderia pseudomallei, but I think the most important thing to note is that, as far as I'm aware, PCR is not being used routinely anywhere for the diagnosis of melioidosis, even in Darwin, where the resource constraints are not so severe. There are, again, new tests being developed, and again, our colleagues in Moru, particularly Claire Churapucha, is developing CRISPR-based tests, and I think, if I'm right, Liz, that one of these is about to be evaluated in long run. Yeah. So watch this space. There's also the possibility of antigen detection, and I should declare an interest here, because since I officially retired, I've continued to act as a consultant in BIOS, an American diagnostics company. They produce a test which detects the capsular polysaccharide, the external extracellular polysaccharide of Burkholderia pseudomallei. And the reason I've done that is because I believe so strongly that we need rapid, sensitive diagnostic tests for this disease. We've actually done a couple of evaluations on this test, or earlier versions of this test, when I was here working in Lao. And in summary, it works very well for identifying colonies and for getting a preliminary identification on a positive blood culture. It's highly specific. And if you can get good quality samples of pus or sputum, then it works pretty well on those, but it's much less sensitive on blood and on urine. The test has been refined over time, and now further studies are underway that are needed to get FDA approval for this test. So that should be happening over the next couple of years. When we've grown the organism on solid media, we need to identify it. The way we always used to do this was using things like these biochemical kits for the API-20NE, or using conventional biochemical tests. But we can also use the approach of serological identification, either using the InBios kit, or there's a latex agglutination test which is not commercially available, but we've been using it for many years, manufactured by our colleagues in Moru. And it gives you a very accurate, rapid identification, or presumptive identification. There's another simple test where laboratories are just beginning to start looking for Burkholderia pseudomallei, which is to look for this characteristic pattern of resistance to gentamicin and colistin and susceptibility to coamoxiclav. And in an oxidase-positive gram-negative rod, which shows those characteristics from a clinical sample, our colleagues in Vietnam have shown that there's